Aaron?
I'm here. I'm finally able to hear everyone. Sorry about that. I had to unplug and replug my headphones.
Okay, we're glad you're here. Can you tell if we have a quorum?
I am scrolling right now. Give me just a moment. I see yourself, Wayne, Melanie. It looks like Doug has joined us. Johnny's here. I apologize. I start to scroll and then more people pop into the waiting room and that throws me off track. I do not see our new member Frankie logged in yet. I'm not sure if he prefers Frankie or Frank. I've seen both on his email.
Frank Huffman?
Yes, sir.
Yes. Is Mr. Hoyt on?
It looks like it. Yes, sir.
Welcome, Mr. Hoyt.
Thank you.
It's just now 10 o'clock and the waiting room is clear. I have Rick, Melanie, Wayne, and Johnny all logged in and Doug. Did I miss anyone else?
Does that give us a quorum?
I believe you're good to go. Yes.
Okay, thank you. And it's past 10 o'clock. So welcome, everybody. I'm Rick Christman. I'm the chair. There's a number of people on the line, and I just want to point out that if anyone wants to ask a question or make a comment, you're welcome to do so. Our first order of business is approval of the minutes for February 6, 2024. Would someone like to make that motion?
I move to accept the minutes. This is Melanie Tyner Wilson.
Thank you.
Rick, my apologies really quick for our new member. When you're voting, your camera must be on. Sorry, I should have mentioned that sooner.
Yes, we want to see your face. Any second on that motion, please?
I will second.
Thank you, Johnny. All in favor, say aye.
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 Any opposed? Any opposed, say no. All right. First order of business is new member recruitment, and we do have some success there. We have a representative of Leading Age Kentucky, and that's Doug Hoyt. Doug is the CEO of the Wendell Foster Home, which is great. Anything else you'd like to say, Doug?
Nope, just glad to be here.
Well, sounds like you're well qualified, and we're glad to have you. And Frank Huffman was also approved. He is not on the call yet, but that leaves us with still 2 vacancies, correct, Aaron?
Yes, sir.
Is that the one, a consumer or participates in a non-residential community Medicaid waiver program? Or do you know which vacancy?
Yes, give me half a second and I'll pull that up for you.
Okay.
My apologies. I should have had that prepared. So yes, sir, that leaves the consumer representative of a family member who participates in a community Medicaid waiver program.
Mm-hmm.
And then we also have a consumer who participates in a non-residential community Medicaid waiver program. Those 2 are still vacant.
Well, those should not be vacant. We should be able to fill those. Melanie, do you have anybody you could recommend, or Johnny, for the
Yes,
consumer representatives?
I do. I've been attempting to recruit from the world I live in. I will, can I get back to you on that?
Sure.
So we have folks, I can get their names and whatnot.
That would be greatly appreciated. Thank you.
Melanie, this is Aaron. If anyone has any questions or are curious for a little more information, you're welcome to provide my email address.
Okay.
And I can also reach out to them as well. You're welcome.
there might be there's something I'm thinking of would also be possibly use an alternative way of communicating, be nonverbal. Would that be okay?
Yes.
Okay.
We do have a member on another TAC who has an assistant who helps
Yeah.
while he is on the TAC meeting. So yes, we make every accommodation we can.
Okay. I'm on that tack as well. So
Oh,
yes.
good. You're the perfect person to do this.
Oh, right. I'll know about that. I'll be glad to help because I do think we need to get a
We do. And
diverse and inclusive representation.
absolutely. And we are making progress. All right. The first item of business is the use of involuntary terminations. I know there was some back and forth on that. I know, Aaron, you're involved with this to somewhat. We brought it up at the MAC meeting, which was just here recently. And I know the chairman of the MAC, Dr. Schuster, is also interested in this issue. So where are we at? I know, Aaron, were you trying to see if we could get the department to send out a questionnaire?
Aaron, I can take that if you want me to.
Thank you, because I was scrolling through my notes, Pam.
So we are looking still at the best way, whether it's going to be to send out a survey or to work through our the QAs and the individuals that work with the providers. There had recently been sent out a bunch of surveys to providers, so we didn't want to inundate providers with surveys,
Right.
because we do want them to respond. But I do have some additional information because our partners with BDID have worked very hard on getting some additional data for the reasons for currently how many people we have that are being served, and our current some of the current reasons. So I can go ahead, I can share those. As of right now, there are 53 active involuntary terminations. So meaning that an involuntary termination notification, sorry, that's a mouthful, has been presented to the person and or their guardian, but the agency is still supporting those. Of those, 23 have been in place for longer than 6 months.
Okay, you have been busy. Yeah.
Yeah, and so then let's see.
You were going to say?
I'm reading my next note about, and that's there's 16 providers, so 23 participants.
Mm-hmm.
And there are 16 unique providers serving those 23 participants.
Do you have any idea how long those providers have been providing services? Is there any are they have they recently begun providing services? Can you tell?
I think we've seen a mix. I don't have it, and I can go back and get that, but we have seen a mix of where sometimes it is new providers and sometimes it is providers that have been providing services for some time. And then I will when I get down into the reasons for involuntary terminations, you'll see that a little bit. But so 23 participants so 23 unique people served by 16 individual providers. So we have some providers that obviously are serving, more than one person.
Yeah.
65 SCO participants have been involuntarily terminated in the past 6 months, but 35 of those were resolved through transitions to other agencies.
Would you repeat that again?
Yes.
Pam, I'm sorry.
65 participants
Uh-huh.
Have been terminated in the past 6 months, but 35 of those were resolved through transition to another agency,
Mm-hmm.
choosing a different service type. So they may have decided they wanted to. Aaron, can you help with
I'm trying to scroll to see who's not muted. I'm sorry.
That's
I'm not
okay.
catching
Thank
it
you.
fast enough.
Thank you. So they've maybe have chose to go from receiving residential to living, to going home with a family member. They may have decided to change their service types from traditional to PDS, or they were not able to return to their services, for example, due to a long-term hospitalization or incarceration. So they had a decline either in their health, and they needed a higher level of care. So they've been hospitalized
Oh,
long term, or they have been incarcerated.
and they are not subject to someone else serving them, I guess, right now.
Right, exactly. They are being served by other people at this point in time. So
Right, right. So what does that mean? So we, the 16 you said were more than 6 months. Were any of those who are incarcerated or in the hospital included?
no,
among the
those are
16?
not. Those
Okay.
are
There's just being served by someone who believes they cannot meet their needs.
right. And so then let me get into some of the reasons that um, that people have issued those involuntary terminations. Now, I will say it can be for any service. The majority of them are for residential services, but it also could be for a different service. So the top reasons that we're seeing are they're unable to meet their needs because there's declining health needs. This is becoming a more frequent reason that we're seeing. I will say we've also had there's been, and this has been in, I've dealt with it more in the brain injury arena, but home health providers can come into residential homes and provide home health services. However, we've had some residential providers that have put up some barriers to that. So we're working through that. So, there it could be a solution if someone has some health needs that can be met by having some state plan services such as home health. They should be able to get those in the residential home because that is their home. So we're working through some of those challenges, but so that unable to meet needs due to their declining health has become a more frequent reason. And as we see the population that we're serving age, that I feel like is probably going to continue to be something that we're going to have to work with. The second one is unable to support the person due to frequent aggression towards other individuals in the home, staff, and or there's been frequent incidents involving property destruction. So we've seen a lot of agencies that have been trying, they've worked with other providers and other services to try to handle that before that involuntary termination is issued. But that is the next reason. And then the next two are similar. One is a voluntary agency closure. So for example, we've had 29 individuals that were had an involuntary termination listed or issued in the last 6 months were from the same agency that was closing. And so when that happens, we have staff that go in and help with those transitions and help to make sure they work with the participants and guardians and their families to offer choice and to help them to transition to a new provider. The other one is when that's similar to a closure, but the provider may not be closing completely, but they are choosing to not provide services in a particular region. And we've seen this when maybe they have a staff that had been serving a particular region resign and they choose not to fill that position. They choose not to continue services in that region. And so we, again, work with the individual to transition services to a different provider. 4 of the involuntary closures from the last 6 months were related to that issue. So 33 of the program closures that were issued, or the involuntary program closures issued in the last 6 months, were due to either agency closures or an agency no longer providing services. So about 50% of the most recent involuntary terminations that were issued were related to those two causes.
And let me see, how many were those? Was it in the last 6 months? Was it 53?
There were 65 in
Oh,
the past
60.
six,
Oh,
65 in the past 6 months. Mhm.
yeah. Let me ask you, how often do you have to deal with agency closures as a challenge? It sounds like that happens more than it should.
It does, I don't have the exact numbers, and it's been a while since I have done that with looking at the agency closures. And I don't know if Elizabeth from BDID is still on. If she knows off the top of her head, that may be something we need to go back and get you, Rick. We can certainly do that.
Yeah.
It depends. I think that one time when I did it, because we monitored it through COVID, we did not have that many agencies that closed. But it's always. I will tell you this. Whatever reason, this is very popular for buying and selling each other. So we do a lot of times have agencies that, they may sell out to another company, or we have a lot of provider changes, but we can get those stats. I don't have those off the top of my head. And I think I saw Amy put something in the chat.
Yeah. What does that say?
Do you have any data regarding how quickly the 35 were resolved and how many of those 35 are served by someone else? I do not have it here with me, Amy, but that's something that we can dive into. We can get that information.
How
Hey,
does it-
Pam.
Thank you so much,
This is
Pam.
this
Go
is
ahead.
Melanie. I had a question in regards to where are these agencies located? Are they concentrated on the east side of Kentucky, west side? Is there a certain county or region that seems to have a clustering of these agencies?
I do not have that in front of me right now. That's something I can go back and get. I do not have their locations. If they're if they're concentrated in one part of the state versus another, or if they serve. Sometimes it may be, we have a lot of agencies that serve across the state.
Yeah.
But we can get that information. I just don't have it here in front of me.
And the last question I had was in regards to the background, the competency of the staff that was working. What are their background areas or areas of expertise? Do they have different kinds of supports in place within the agency that would be able to meet a certain type of special person, that it would be within the agency, like a
Yeah.
behavioral therapist or a aging caregiver.
We
I don't know if you understand
Yeah,
what
I
I
know where
mean,
you're
but
going. Yes, I
okay.
do. And so the minimum staff requirements are listed in the regulation,
Yeah.
and that but we encourage providers, especially residential providers that are going to be, taking on individuals that, are going to be served, for the most part 24/7,
Right.
to look at who they accept and what the qualifications are of the staff. They always can require more quality, can require additional trainings of their staff. But we do not have, we have, who we monitor for the trainings and the requirements that are in the regulation, but anything above and beyond that,
Yeah.
we do not have that.
Okay. Thank you.
Can you, do you have any estimates and of the unable to meet healthcare needs of that 65? Is that a large percentage of that?
I do not have that number. I can try to get that. But I don't have that number.
Do you think that's the long-term, solution to this issue that may be growing is to try to get home health involved? Is that adequate, do you think, Pam, or?
That it depends. It
Uh-huh.
really depends on what the individual's needs are going to be. So, home health certainly may meet some of those needs. And then there may just be some individuals that their health declines to the point that it's not even that them receiving home health would meet those needs. It's really going to be that individual and what needs that they are having at that point in time. It may be something that they're able to, you know, recover from, and
Mhm.
then they're able to then function in the community like they were before, or with enhanced supports. It may be that they're not able to be their needs aren't able to be safely met
Mhm.
in that manner anymore. It really is going to depend on the individual.
What's the outcome then? Skilled care nursing, do you think?
It
What?
depends on, it's going to depend on what the
Yeah.
individual's
But it
needs
could,
are. It
I
really,
know that.
it
Yeah, of
could
course.
be. I mean,
Yeah,
it could be, right. It
Yeah.
could be that could be what is the best. I mean, it's truly is, you know, we want individuals to be able to choose their placement. Community is always the best, but we want them if that's what they want. But again, you know, it's also going to be up to the individual's choice and where they feel safe and where they, you know, how they want to be served. So I mean, it's truly is going to be person driven based on what needs they have at the present time.
You know, under those that, because the reason is aggression, it would be, I think it would be interesting to know that how many different providers have been attempted with some of these people. You know, are we dealing with a few people resulting in a lot of terminations, or you don't know what I'm asking here? Are we really talking about a small group of people that are responsible for most of the terminations? Or
Are you
I think
asking
it's
on
worth,
the
I think it's,
provider? Are
yeah.
you asking on that? Is it the providers that
No,
are?
the individual. I mean, do these individuals go through a number of providers with, I mean, I'm trying to determine how big this problem is, and is it being generated by just a few people who are difficult to serve, or is it because we have some agencies or providers that need to improve
Hmm.
themselves? Does that make sense?
It does, yes. I
Um,
don't know that I don't have an answer. I know
I'm
I do
sure
not
you
have an
don't.
answer right
Yeah.
now, but I see where you are going. So, and I honestly think it's going to be a little bit of both,
Yeah.
Rick. I think it really is, because I've seen, in particular, when we get new providers, they just want to take on, you know,
Yes.
they're just taking on individuals without truly looking at what kind of qualifications are my staff going to have to meet their needs. How am I best going to be able to serve this individual? And then looking at the mix of people that they're putting in the home together as well, because, you know, that plays a part in it.
Well, that's why I asked the question initially, is that how long have some of these providers been providing? And some of them, it has been a short time. Well,
And also, Rick, this is Melanie.
uh-huh.
I think about all the things that we experience as a population, you know, where people get cancer, people get COPD, diabetes, you know, all those kinds of things. And would that be a reason, in terms of their eligibility being discontinued because the capacity of the individual has been impacted and the current staff doesn't feel comfortable providing that level of care to someone?
Mm-hmm.
Because you can have intellectual developmental disability and have cancer,
That's right.
and you know what I'm saying. And so I think that
True.
is a whole journey, because we have individuals that are, you know, ancient like me, that, you know, get all the issues and concerns that and other people get as they get older.
What is your feeling, Pam, and also the other members of this committee about developing some kind of questionnaire that will drill down on some of these questions? What do you think, Pam? Do you think if we don't, there's some things we don't know. Would a questionnaire help us learn those things?
If you get a good response and people filling it out, that's going to be
Right.
your.
Yeah.
Mhm.
What's your personal opinion? Should we do one?
I mean, it's truly up to you all,
Yeah.
as the TAC.
I know you had some questions too at our last meeting, or some concerns about, providers not attending plan of care meetings and case managers. I don't know. What do the other members of the committee think? What do we have a problem here? Is there something we need to know more about? Is there something that we need to make recommendations? Anyone?
Hey, Rick, I'll jump in. I think it'd be good to know more about, even though this group of people, maybe, small in number, still, we want to do whatever we can to make sure that whoever, needs services gets them. I, I've been told that there are a growing number of people stuck in psychiatric hospitals who have waiver funding, but for one reason or another, they are, in a psychiatric hospital in a psychiatric setting, but no longer need to be there, but can't find a provider.
Oh, yeah.
So they're kind of in limbo and just stuck. So I think that's a problem, and I don't necessarily have a solution, but one that I think maybe we need to look at. How do we, get folks out of an institutional setting that they no longer need to be in?
Pam, those people that are in psychiatric hospitals, would they fall under the category of unable to meet their healthcare needs?
It truly all really depends, Rick, on what the individual, on the individual. I mean, I can't speak. Could be that they,
It could be.
it
Yeah.
could be. I don't know. I don't know what that, what those individuals, I don't know what the needs were that placed them in the hospital or where they are now.
And Pam, this is Melanie. Along those same lines, you can have someone that has maybe their wisdom teeth coming in or a toothache, but is nonverbal and has aggressive behavior as a result of internal pain that they might be experiencing. So it's like it's so hard, in some situations to be able to kind of hone in on exactly the antecedent, why is the behavior occurring.
Mm-hmm.
So
That's absolutely right. Well, I don't know. I know a few years ago this seemed like a hugely critical problem. You recall that, Pam? That there was just a lot of providers who were concerned about this issue. I don't know if it's gotten better or worse.
Rick,
Yes.
I don't think the concern has gone away. I think providers still consider it an issue. I think finding, the information that helps us solve the issue is something that's of concern to this committee anyway. Whether that's done through a survey or some other means, maybe that's what we should be talking about.
That's what we are talking about.
Yeah, absolutely.
So what's your opinion, Wayne?
Well, I think, we started out to do a survey. I don't know why we don't go ahead and follow through with that and obtain, the numbers that Pam gave us today. Just looking at those, it's quite concerning. I think we follow through with the survey, and I know providers, feel like they're overwhelmed already with surveys coming at them left and right. But I think if it's explained the importance of this particular survey, then I think they won't mind filling it out.
But there's still a concern that many won't, I guess. Or, the ones that are having a problem probably may not. Well, I agree with you, Wayne. I think we should send out a survey. And Pam, do you think enough time has passed that a survey would be responded to?
Yeah, I have the question list that you all had sent, so we can work on
Okay,
getting that issued.
okay, so why don't you and I just go back and forth, Pam, and we'll finalize that survey.
Okay.
How about that?
So
And we'll try to get it submitted before our next meeting.
And yeah, the end of the process,
Does that sound reasonable, Pam?
That is fine, Rick.
Okay, thank you.
I'm sorry, Rick, this is Erin. Can I butt in for just a moment?
Uh-huh.
I'd like to make another request. If you're not talking, please stay muted. There's a lot of feedback and a lot of noise going on, and it makes it hard for the court reporter with the minutes. Thank you.
I agree. We're hearing a lot of noise in the background. Okay. Let's move on to the next agenda item then. Number 6, CareWise prior authorization letters of intent. Amy, did you have something?
Hi, yeah,
Said
thank
about
you so
that?
much, Rick. Thank you. I bet when I put LOI in my request, it was actually to mean lack of information request, not letters of intent. So that may
Oh,
help
I'm sorry. I was trying to interpret that.
It's okay. The Pam, I know that you talked about this earlier in the year, and now we're kind of in April, and I know that you all have been working really diligently with the people at CareWise to kind of get those prior authorizations running smoothly and updating the processes, etc. I am still receiving feedback that some are taking over 30 days, and I just wondered if you, due to primarily what I'm hearing is LOIs that providers / case managers are receiving. And one of the top complaints that I have received feedback on is that the folks over at CareWise are asking for documents to be emailed that already exist within MWMA, and maybe they just don't know where to find them. And I didn't know if you had any kind of updates about all of this, how that's going, etc.
I need those sent to me and the examples and who it is so that I can address it. So I do know I'm working with a provider and working with CareWise on an issue that we had previously addressed with them about asking for second identifiers on pages. And so I've been addressing that with CareWise, but unless the provider tells me and sends me the examples so that I can address it with CareWise, I don't know what to address. There shouldn't be any request for anything to be emailed because the documentation needs to be in MWMA. So I really need to know about those, but we can't address that with them if I don't get the examples. And it really helps if we get the cases so that we can identify, if there's a particular person maybe that just needs some retraining.
For the
Thank
benefit
you
of
so much.
everybody. Oh, go ahead. I'm sorry.
I was just going to say thank you so much, Pam. For you specifically, it would be the easiest way for providers to email you directly, submit a case to the help desk. Which would you prefer?
Either one
Okay. Okay.
Either one.
For just the benefit of everybody else on this call, Amy, would you like to explain what CareWise does, what their role is?
I
What they do?
can.
Yeah.
Sure.
So Amy, do you want me to do it since
Oh,
they're
go ahead,
actually
Pam.
our
Yeah.
contractor?
Yes,
Yeah,
thank you.
maybe it's
So-
better for Pam
Yeah.
to do that.
I'm sorry. Go ahead, Pam.
So CareWise is a subcontractor with Gainwell. They are our utilization management contractor. So they review for this group. What's relevant to this group is they review the waiver level of care and plan of care reviews on behalf of Medicaid.
Right. And so they may have issue with some of the billings, I suppose, if they don't have all the required
Well, it would be for the plan of
property.
care. So if there's
Yeah.
not all the required documents or the level, it could be the level of care, all the required
Right.
documents.
Okay.
That's why, and once Amy gets me those examples, then can dive into that a little bit more and see if there's a pattern or what's going on. So we'll figure it out.
We'll do that. Thank you. Did you still want to speak about audits, Amy? The CareWise audits?
Sure. A provider letter was sent out, goodness, at the beginning of January. I'm not going to remember the exact date, but regarding the new CareWise function of billing audits.
Mhm.
And I am, I don't know that anyone has reached out to me and told me they've had a billing audit yet, but I just wanted to know if you could walk through that, if there would be any changes in the billing audit process from what has been done in previous years,
No,
etc.
it's the same audits that the state staff or one of the sister agencies were doing, whether it be Dale or BDID. It's the exact same billing audit. So it's looking at believe this year. Let's see, we're in 24. I think they're looking at last year. And let's see, they're looking at 22 because we give a full year of timely filing. So since we just started 24, we're not looking at any of 23 yet. So it would be looking at billing that was occurred for services provided in 2022, and possibly they may go back just a little bit further if there was some that had not been, there were some audits that hadn't been done, but the provider will be notified of what time frame we're looking at. But they truly are, it's the same process that was done by either us or BDID or Dale, and it's looking at, now we also look at the EVV records. It's looking at the billing compared to the authorization and service documentation. So it's the same audits just being done by CareWise versus state staff.
Can you talk a little bit about, obviously, particularly 22, that time period we're dealing with? We are obviously operating under Appendix K. That was a period of time where Appendix K guidance changed several times. So how is that being accounted for in the audit process to ensure that providers aren't facing potential recoupments for, just an auditor looking at the wrong guidance comparing that to the wrong date of service, etc.
Yeah, so all of that document is part of, they have that as part of their audit tools. But in addition, there will not be any recoupments issued without, there will be, my staff will, or BDID or Dale, some of the cabinet staff will also look at those before any final decisions are made if there are anything that's identified as a recoupment.
Okay, perfect. I think that's
And
all I
so,
have on
we
that.
realized that there was a lot of stuff like where limits, the limits weren't in place, or, there was, I think some overtime. What we're really looking at is where there is no documentation at all of the visit happening. And like I said, EVV plays a huge part in this, right? Because it's so much easier as far as the documentation and capturing the visit. But we're really focusing also on providing a lot of technical assistance when we see kind of the outcome of that, because we realized the whole, 20 through 22 or through 23 was a little bit crazy, or a lot crazy, and things changed frequently. We also had 2 natural disasters in the middle of that. So all of that is going to be taken into consideration.
And is CareWise doing the PDS audits?
I do not know the
traditional?
answer to that. Right now, I know they are doing traditional. There's a lot going on with PDS right now. So right now they are doing the traditional audits, but they may also be doing the PDS. I need to ask someone on my team, because for some reason that answer has totally escaped me at the moment.
Awesome. And just an FYI, Rick, when we get to the PDS agenda items on the agenda, I'll probably be talking about them in bulk and just for Pam's information too.
Yes, that's what I was going to ask you. And before we get into that, another point I was just thinking of, will be some regulation changes coming up, and PDS is just growing in its importance, and we don't specifically have someone on this committee representing someone who receives PDS, either as an individual or as a family. Could we, at some point through the regulation, add a representative for PDS on this committee? What would be required to do that, or should we do that?
Rick,
I'm sorry, Johnny, go ahead.
well, I was just going to say Frank Huffman has now joined, and Frank, I'll let you
Okay.
yeah, confirm, but I think Frank also is a PDS participant.
He happens to be a PDS participant.
Happens to be, yeah.
But we don't officially have a PDS representative.
You're talking about adding it as a required member.
Yes, yeah.
Not just by chance, I see.
Yeah.
Okay, Rick, this is Erin. Yeah, Johnny, you beat me to it in the chat. I was waiting for Pam and Amy to finish up so I could let Rick know our new member was on. So welcome, Frank, or Mr.
Yes.
Huff, or Frankie. I'm not sure which you prefer. But to add a member, we will have to have a regulation change, and I would have to honestly figure out, I'd have to reach out to the governor's office. Since I have been on, we've not added anyone. We've just appointed. This is one of the few TACs that has governor appointed members as well. So I would have to probably get higher up clarification on that process, but I believe it would be like a statute regulation change.
Yeah. Oh, a statute regulation. I mean,
yeah,
a law would have to be passed.
Some of them were brought in through statute, some of them were brought in through regulation. So I'd have to do a little digging because this one does have governor appointed members. So I'd have to refresh myself on everything. But I think it's more than just finding a member and having them appointed. I think there would be some legwork that would probably take several months to do, at least several months.
What is the feeling of the committee? Is that something we would like to go through that process to officially add a PDS representative? Any feeling, any opinions on that? No. Okay, that's why we rely on this committee for guidance.
No, Rick, this is Melanie. I think that's a great idea, and to have to be actually honest, there could be an individual that it personally oversees their PDS program, as well as maybe someone that maybe has a different level of needs, and that maybe a caregiver, family member is the one that's the overseeing of their PDS plan.
Okay. Well,
Rick, sorry, I was going to mention too, these are public meetings, so you are welcome to invite, and they can reach out to you if they have agenda items. So if you know someone that would be willing to come and speak and bring some of these issues, that's always an option too. For now, if you are looking for a voice, because they are public meetings and they're welcome to anyone who'd like to join.
Well, I think that's what we've done with Frank. But I just wondered if we would want to go beyond that. And why don't you, Erin, look into how much rigmarole we're talking about here?
Will do.
Okay, thank you. With that said, Amy, if you'd like to help us with these next 4 agenda items, that would be great.
Okay, thank you. And I'm going to preface this with, Pam, I don't expect you to necessarily have very specific answers to these. I'm going to just talk about these things broadly, but over the past 2 years, obviously, we have seen an increased need and desire for PDS, which is wonderful. We have or are in the process of expanding who can be a PDS case manager for both the home and community-based waiver and the Michelle P waiver, which is great and wonderful. But with these great and wonderful changes, we've also seen a really tremendous increase in issues. And really, this is kind of what I'm hearing are the chief complaints are. Number one, I think that, and I think this is something that we can work out by reg, et cetera. So just things to kind of think about as we move forward. The roles in PDS related to the case manager, the individual's family, the FMA, et cetera, they're not very well defined. And depending on where you are in the state or which providers you use or which team you're on, it can change. And I think it creates a lot of confusion about who's supposed to be doing what. And I think that in order for the system to function really well, those roles and responsibilities, who is responsible for doing what, need to be really honed in and well defined. And I think that along with that, there is a really strong need for family member education for PDS, or the individual education, exactly what the roles and responsibilities are when it comes to being the employer. Because right now we hear reports from case managers that are being asked to do things that they really should not be doing. FMA is being asked to do things that they really should not be doing. And there's just a lot of confusion out there. And in guidance coming from different agencies that have hands in PDS, whether that be Dale or BDID, and none of the guidance is incorrect, but it does differ depending on what waiver we're talking about. And again, it just creates a lot of confusion. The standards seem to be different depending on what waiver we're in, et cetera. And so I think that as we move through this year, as we move towards creating new regulations, kind of streamlining lots of things, that standardizing the process across the waivers, creating strong or really specifically outlining everyone's roles would just be such a tremendous benefit to everyone and really improve the PDS service for everyone involved.
I see a hand raised. Frankie, did you have a question or wish to make a comment?
Yeah, I didn't know if I should mention, but not only do I do PDS on SCL, but I'm also the representative, so I oversee like the people I hire and things like that.
Yeah, and we're happy with that because that makes you a good representative for PDS. I guess I was just trying to get it more formalized in the regulation. Did you have any other question right now, Frankie, or comment regarding PDS?
I also wanted to mention that I do agree with what you guys are saying as well as there needs to be more training on what the case managers do when it comes to PDS and what the representative does, because there's a lot of people that don't understand that as as well. So
Yeah, thank you. Amy, would you like to continue, or is
Sure. And again, I think that, and obviously I have encouraged various members of teams, case managers, individuals, et cetera, to really write into that Medicaid public comment email, because I do know, again, we will see changes, eventually to waivers, improvements, et cetera, with their thoughts about how to make that system better, what the pitfalls are, the points of tension, et cetera, because I do know that you all check that very frequently. So hopefully you are getting some feedback. Can you please provide us with an update on the process of the expanded case management for both HCB and SCL? Are those active, right? Like people can actively apply to start that now?
Yes, so for SCL, it didn't really change because it already was open the way.
Sorry, I meant
Yeah, we're
Michelle P.
changing. Yeah, we're changing. I think
Sorry.
you probably did. No, we're changing all of the other waivers. So the other four, Michelle P, HCB, and both ABIs, it is open. PDS case management is open. We've actually, Ordell on our behalf has certified 9 new agencies to provide PDS case management. We've received 3 applications for providers wanting to be financial management agencies. So far, unfortunately, we're still struggling with those and really struggling with people understanding what the financial management agency's responsibilities are. So, for example, we got an application and their staffing plan was a nurse and 2 CNAs. I mean, and this is somebody who's going to have tax knowledge, know payroll, because that's, what they're going to do. They're going to do all of that on the behalf of the individual. We are actively drafting the RFP to have a statewide or possibly up to 3 statewide FMAs. So that is coming soon. We are under a corrective action plan with CMS right now about our PDS, or for the court report. I don't think we've ever mentioned it's participant directed services. So I think we've all said PDS and had not ever spelled it out. So for how PDS is functioning in Kentucky right now, I will tell you, we've identified lots of opportunities for improvement. We're working on education. I've seen a lot of case managers that are doing things that are part of the participant or their representatives' responsibilities. For example, they felt like it was their responsibility to approve or set the rate for the employee. And that's not the case. If you are a participant directing your services as the participant or with the help of your representative, you get to set the rate for your employee based on what you feel like they need. You have the guide rails of, it cannot be lower than minimum wage. It can't be higher than the max allowable, but it's up to you to decide what you want. It's up to you to decide the services that you need. So we're really starting to work on some education about that, how we can kind of revamp this whole service delivery method, and so that it's better understood. We're going to roll out, we did an employer responsibilities tool. We developed that several years ago. We're looking at that again now and going to roll that out to be voluntary use in the beginning, but it really goes through all the different points with the participant and their family or their guardian, or who they choose to help them if they choose to do so with participant directed services. It outlines, here's what your responsibilities are. Can you do this yourself, or do you think you need help with that? And if you need help with that, that's okay. How do we get you the help so that you can do that? But really making sure that if somebody elects to participant direct their services, that they understand what that means, and that we don't have, families that say, well, I just need my $30,000, and not understanding that it's tied to a plan of care, and that really that participant has goals and objectives, and this is what's important to them, and this is what they want to do. Maybe they want to be more involved in the community, so that's going to involve their employee, helping them, facilitating that, maybe learning the bus stop, or learning travel, or helping them to join groups, or going with them. And it's really all about the participant and that individual's participants needs, not just about somebody saying, I want to provide 40 hours of care. Obviously, if the person needs 40 hours, that's awesome and that's great. But if they don't, and the participant's like, really don't want you in my face or in my house, that's okay too. So, we're really trying to look at participant direction and how to make it better. And Amy, you hit on a lot of the points that we're working on to really try to make it better. We were fortunate enough to go to the Applied Self-Direction National Conference a couple weeks, I guess now it's been a couple weeks ago, and we presented basically on where we are in Kentucky with participant direction and in particularly legally responsible individuals, and how kind of our plan went off the tracks a little bit and how we're revamping that, and received a lot of good feedback. And it was a fabulous conference. So we brought back a lot to apply as we revamp participant directed services, because it's an important delivery. It's an important delivery method for a lot of people. Nothing wrong if you want to get your services through a traditional provider, but if you choose participant direction for all of them or even some of them, that's great too. So we want to make sure that we're serving the individuals to the best of our abilities, and that we are giving them the opportunity to get the most out of their services.
Pam, when you mentioned something about having 2 or 3 intermediaries developed, is that the idea to replace the area development districts?
This will be, so it will no longer be, FMA will no longer be a service. It
Okay.
will be something that we have at least one, probably no more than 3. We are in the process of writing that RFP right now. So I'm hesitant. I don't want to talk a whole lot about that because I don't want to exclude anybody that may be interested in participating in that process when we get further down the line. But yes, it will replace. This is how most other states function, is that they have either 1 or 2, sometimes 3, depending on how big the state is and how it's set up, fiscal management vendors that do that function for participant direction.
That strikes me as a good idea, to have organizations that are just more focused on that role, as opposed to the area development districts that have lots of different responsibilities. So
there are a lot of agencies that is what their whole and their sole focus on is
in other
is
parts of the
doing.
United States, you mean?
Yes.
Right.
Yes.
Yeah, I think that's a good idea, personally. That's good to know.
It's a hard job. There is a lot to it. There's a lot to do with tax and labor, and that I just don't even claim to know enough about to speak intelligently about it. So
Yes, it's very complicated. Amy, is there anything else?
No, but
okay.
Can I just give a shout out again? I know I shouted out that Medicaid public comment email address. They really do read it pretty frequently. So if anyone is on here and has thoughts or ways to improve the PDS system, or very specific issues that they've identified, that Medicaid public comment email address is a good place to send those things.
The next item has been kind of a standing one. Timeline for implementing rate study, waiver design, and children's waiver. Pam, can you enlighten us on that?
I am waiting on our final budget.
Okay.
As soon as we get the green light on what that final budget is, then I think we'll be able to start speaking about that and outlining those timelines. I will tell you, kind of waiver redesign really has not stopped, and this will kind of, as we talk about 13 and 15, you'll kind of hear work that there's still work going on. We're still doing a lot of things. It's not that we're not doing any work pending the budget, but I can't give you any timelines or any final, any plans until we know kind of where we're going.
That leads me to a motion or a recommendation I would like this committee to make to the MAC, and I'll read it off. As the biennium budget is essentially known, and the beginning of the new budget year is only 2.5 months away, the IDD TAC recommends the Department for Medicaid Services release its current plan for the implementation of the various provisions of the biennium budget as soon as possible. The department should also provide opportunities for input from providers before associated regulation changes are released for public comment. If someone would like to second that, we can have some discussion. That's a formal motion I'd like to make. I have made.
Rick, would it be helpful if I gave members of the TAC an update about what is currently in the budget?
Sure.
Okay. So the
Maybe then we can get them to
budget-
respond after this. I don't know.
So as Pam noted, the budget isn't final yet, but essentially it is. The House and the Senate conference committees have passed it, and it has now gone to the governor's desk, where he has line item veto power. After the governor looks at it and may or may not make any sort of vetoes to the budget, that's yet to be seen. The legislature has a few legislative days where they can come back and override those vetoes if they choose. So currently, the budget, as the budget stands, there are 750 Michelle P. waiver slots over the 2-year budget, 375 SCL slots, 750 HCB waiver slots, 50 ABI long-term care slots, funding for a serious mental illness waiver, funding for a substance use disorder waiver, $94 million in general fund dollars with associated federal funds too, which I think is over 100 million in each fiscal year, to fund the 1915C rate study, funding, a little bit of funding to get us to the next budget to help establish the children's waiver, and there was language inserted in the budget that would require the Cabinet for Health and Family Services to conduct an analysis and assessment of the wait lists for all the waiver programs, and present that information by October 2024. So that's where the budget currently stands for anyone interested.
Thank
Rick, this is Leslie Hoffman, Deputy Commissioner. Of course, as of today, we are not able to make any comments related to the budget until it's completely finalized. But thank you, Amy.
Right, and so I guess the intent of the motion is to get this information released as soon as possible, and I understand from the Assistant Commissioner that that will happen as soon as, I guess, the legislative session is over. It also contains, this motion contains a provision that we have provider input before any regulations are proposed to the public. I'm still looking for a second to that motion. Which dies because there is no second. And we'll move on to the next agenda item. How are we coming along with the eligibility assessment tool for children?
We have a work group that is comprised of multiple people from the cabinet. So it's from Medicaid, BDID, Dale, that are looking at not just the functional assessment tool for children, but looking in general at the functional assessment tools we currently use across all populations.
Thank you. Have you narrowed it down to some?
No, we have not. We are in the process of talking with other states and looking at what other states use and have found to be successful.
Are there quite a few different examples out there, would you say? that you know
Everybody
of?
does things a little bit different. There
Okay.
are some that are more, I think, more prevalent. It really depends on kind of the population that you're serving
Mhm.
and the waiver programs, what you provide. So
Okay. We talked last time about perhaps having a presentation on mobile crisis units. Do we have someone
Rick,
available?
this is Leslie Hoffman. I'm going to give you an update. I feel like I repeat myself a lot. Just forgive me because I've got the behavioral health TAC and then the max, and I'm asked to present a lot in reentry. So just bear with me. But I do have a presentation I can share with you after today or
Okay.
today, and then that way you'll have it for information. And I'm going to share screen if let's see. Aaron, can you double check if I can share screen? It says one at a time. And it looks like it's going to let me. Just a second. I'm getting there. So again, Rick, this is probably more than you want, and it's probably a lot of repeat from what you've heard before, but I didn't want to leave you empty-handed this morning.
Well, I think above all, we're interested, does this affect people with intellectual and developmental disabilities?
It does. And so
Yeah.
let me skip. I'm just going to skip through this real quick. Of course, I wanted to go over this with you just real quick. It's an all-inclusive model for Kentucky. That means it does cover waiver clients. Now, depending on where they live, and I'll get there in just a second, it's to ensure that behavioral crisis for any person, any resident, anywhere, anytime, and no wrong door. We assessed Kentucky's needs for behavioral health crisis, and we evaluated those in our current landscape. If you are wanting to know where we started, it was based on SAMHSA's national best practice guidelines. And again, I'm moving through this very quickly, but I'm going to send this for you to have today. And if you have questions, absolutely contact me. This is just how we got started, and this was
Leslie?
our planning grant. Yes, ma'am.
Your screen's not sharing.
Oh, I'm so sorry. Hang on,
It's
let me
okay.
try again.
It did there for a minute.
Hang on just a second. Well, I'm getting ready to get a storm here in this area. Let me see. I'm so sorry. Hang on just a second. Can you see it now?
Yes.
Oh, sorry. I've definitely got a delay here. So you just bear with me. I'm getting ready to go into storm soon. This was just the beginning of how we started with mobile and the planning grant and all the folks that we involved and how we drove every decision we made. So, if you can see my screen, this click here will take you to a 258-page needs assessment. There's about 20-page executive summary if you wanted just to go to it and kind of look over the summary. That helps for folks to know why and how we went the direction we did. Again, I'm just going through this really quickly. This is to develop our assessment and findings, and what we needed to do here was not really a project management change. We had to do a change management, or not a project management. We did a change management approach where we evaluated what we currently have in Kentucky, how we can leverage all the good work and the bits and pieces that we have across Kentucky, and how we can move forward and leverage those as we go. This is just how we kind of had our gaps and our meeting our aims or our goals. I think I was asked on another committee just recently, how are your goals looking? And so far we're doing well. In Kentucky, you might already know this, we decided based on that needs assessment that we needed 2 models. One here in Kentucky that the federal government put out in the show letter that said we would have 2-person team who would be on that 2-person team available 24/7, 365. And that if we met that criteria, they would give us 12 quarters of enhanced funding. But we also realized in a very rural Kentucky, where 112 counties of 120 are rural, that we needed to develop something else. And so that's when we developed our community co-response grant program that would go out to primarily 911 dispatches where local municipalities would be involved. So the governor allowed us to roll out, if you've heard him announce, roll out grants. Our first round of grants went to these folks, which was the Bull County Fiscal Court, Christian County Fiscal Court, Cynthiana Police Department, Lexington, Fayette Urban and County Government, Maysville Police Department, Perry County Ambulance, and Warren County Sheriff's Department. And this allows us to help them, give them technical assistance, startup money, and understand the mission and values of what we want to go on here in Kentucky. So we know that although we want to minimize law enforcement involvement, we know that it's going to happen in our rural Kentucky. And how can we help these folks to maybe bring on, for example, social workers? If you all have seen lately, there's several, I think Bull County and maybe one other, Maysville, both have licensed clinical social worker positions posted out there to bring on to their groups. So I'm very proud of these groups because it is very humbling to see a Bull County or a Maysville Police Department wanting to help their local community and their neighbors next door, and to do it in a way that is to fidelity and to help these folks in a way that meets their diagnosis and their exact need. You've heard me say before that a person with a mental illness or a person with depression and anxiety in the LGBTQ community is not the same response as we want with an elderly person that's maybe having a behavioral health crisis and also has an episode of dementia. Just going over this real quick. You've heard me say this before. This is kind of where we wanted to go. Someone to call, someone to respond, and a place to go. This one lays it out a little bit easier for you. If you heard me speak at Health and Welfare, it gives kind of a definition of each one of these items. So that's a little bit laid out a little bit different. These were the goals that we've met so far. I won't go over those, but you have them. Sorry, let me go down one. I apologize. I'm moving through this fast. The Administrative Service Organization is Carillon. We put out an RFP. Their expected go live date is June 1, but that is subject to change. Our current activities, and this is where I wanted to go with you today, we're really right now in the contract and provider network phase. We've met with all the CMHCs, all the CCBHCs. We've met with all the MCOs, a couple of BHSOs at this point. We started out with our safety net, the CMHCs first, and now we're also starting to meet with other interested providers that can meet the qualifications. And again, I can go through that later. So what does that mean for SCL or other like the brain injury waivers that have residential components? CMS has allowed us to include a community residential setting, such as a 3-person home that you might have in the ABI waiver and or the SCL waiver, as a qualifiable location that we would need to assist. When you get into group homes, that's a little bit different because it is a licensed facility. Cannot go into nursing homes. I cannot go into licensed facilities. So I just wanted to let you know I was actually pleasantly pleased that that CMS would allow that. It also would cover folks who live on their own, independent, shared living. I need to check on the family foster care, but I believe it would allow for that as well. So just wanted to let you know that if it's a residential setting that's in the community and there's a crisis that's called, and it truly has to be a behavioral health crisis, then we are able to assist. Now, Rick, there is a lot more to come on this. Right now, we're really trying to establish those contracts that I told you about, the introductions, collaborations, and meetings. So in the next 3 months, I'm guessing that you might want to have me or one of my staff to come back and start explaining where we are. But really until June probably is going to be like a lot of behind the scenes kind of stuff going on that the public's not seeing. And because it's contract related, we did come up with, Dr. Schuster asked for some service definitions the other day. Aaron, I don't know if, has that been shared with you from Lee or Eric? The service definitions for the behavioral health TAC. If not, I'll get those to you.
Not off the top of my head, but I can go back because, you know, that was 2
you're
weeks
fine.
ago.
I believe Leanne may have sent those directly to Dr. Schuster, so I can get those out. We're sending those out with any contracts that we've got, so that folks can better understand what the service definitions are and what they look like. I think everybody right now has the fear of the unknown. With any new program, it is the fear of the unknown, and we're trying to close down any gaps. We will have growing pains. I'm just going to tell this community right now, we will have growing pains. We will have gaps that we will identify. This program is of such magnitude, there is no way that we can't have growing pains. So we will. We did partner with our with the Department of Behavioral Health. We are connected to their 911, their 988 call center. And then our ASO picks up where deployment needs to be made. So the CMHC 988 call centers will take a call, triage, and then decide whether deployment needs to occur. And then it'll all go through our administrative service organization that we are collaboratively working on together. Again, that's probably more than you wanted, but I will send it out. And then if you have questions later, feel free to reach back out to me. I'm sorry, I'm like jumping around here. I did put, so we have a specific Kentucky Mobile Crisis.ky.gov that's picked up every day. And then there's my personal email. Just make sure that you can label it that it's related to mobile crisis or that it's related to the IDD TAC so I can get your answers to your questions efficiently. That's it, Rick.
Well, Leslie, you have a lot going on there. That is
I do.
That is very impressive. You just heard us speak earlier about, involuntary terminations and people being served, with by people, like organizations that really don't feel that they're capable of doing so. And some of this is related to aggressive behavior. So would this be something that would be appropriate for a mobile crisis unit to help deal with?
So Rick, I'll have to work with Pam on this too, and we'll probably have some parameters that we need to let folks know. There are some situations that a provider would be expected to handle, correct? And then there will be some that are outside danger of self and others and things like that that we'll have to identify. I will tell you though that we absolutely want to be able to respond to the IDD population as well as the ABI population and what their specific needs are. You're aware that I used to be in Pam's position, so I know quite a bit about the waivers and the populations we serve. And we want to make sure that we meet that need. Now, the other piece to this is absolute diversion from hospitals, ED, the emergency room departments, psychiatric facilities, and jails. So those are other things that I'm getting some feedback, sorry. Those are things that we would all want to work on, but Pam and I will have to come up with some parameters the closer we get as to what would warrant a behavioral health crisis, right?
Right.
A lot of folks, I'm aware too, have dual diagnosis, so we'll have to work through that as well. But I don't want to speak too much for Pam because we will have to work on this together along with our sister agencies, including the Department of Aging and Independent Living.
Right, and the plan also includes places to go. How many places to go?
That is correct. So currently right now we're working on an expanded residential crisis stabilization unit, and we are also working on a 23-hour facility. Now that's not one facility. We're hoping that lots of partners will come on, and that's part of the contracting and the service definitions I was telling you about. We're trying to develop, I don't know if anybody's familiar with the old living room model that used to be in Louisville, Kentucky, and I think it's no longer there due to funding. We're trying to develop something that would look like a 23-hour. As you're aware, oftentimes we just need to remove the audience sometimes or isolate the situation for the member. And especially with younger adults, it might just mean that the families need to be a part, for 7 to 8 hours or a day, right? And so we're trying to work on that. So the 23-hour would truly be 23-hour or less time away, or we also are going to work on a residential crisis stabilization expansion where folks can stay a little bit longer. But since day one, it has been our desire to eliminate as much as we can unnecessary law enforcement. Now, there's going to be some situations that it is necessary, unnecessary law enforcement, and then diversions from all those types of facilities that we told you about. But again, Rick, I think probably after June, you might want to ask us to come back and give another presentation.
Yes, we'll do that. And I do agree, sometimes just changing the environment magically can change a whole situation. So this sounds like a great idea. It was mentioned last time that, if I understood you correctly, that you're going to still look at, how the SEL is prioritized, based on the urgency of need. And you're working, did I understand you that you are working on the same thing for Michelle P?
We have an entire work stream that's looking at wait list in total. So it's looking at how SCL does it today. It's looking at how Michelle P is set up today. It's looking at how other states have also structured their wait list. So it's not to say that it's going to be just like SCL. We may find things we want to change with SCL, but there is a plan to go away from just having the general wait list where it is allocated just in chronological order. We are looking at options for that, but there is a collaborative team that have been looking into that.
That's great. I think that's a great idea. And then you also mentioned, are you still working on plans to try to eliminate, I mean, not to eliminate the category, but I know like emergency always has like 0, and you're trying to make urgent a 0 too, correct? As time goes on.
Right now we are down to only 38 individuals in the urgent category on the SCO wait list. There are 3,477 individuals on the SCO wait list. We have 38 in urgent and the balance in future planning. So 34, 39 in future planning and
Would
0 in emergency.
Would that involve then keeping some of these new slots open for that purpose? The new slots that have been coming from the General Assembly.
It depends on what that final count is. And, that
Yeah.
is something that we are reviewing. And, and again, I want to, remind anybody at any point in time can request emergency funding, whether they're on the future planning list or on the urgent list. But we have been working very diligently. As you can see, the numbers on urgent have went down considerably. We're at 38 right now. So.
But that depends on, do you have the slots to do it, right? Do you have?
Correct, because we always want to make sure we have enough slots that we don't ever have anyone that needs emergency services on a wait list. And we've been able to manage that very well for the last several years. And so it's always looking at that to determine how many how many slots we save for emergencies to have for those emergency allocations. But I do believe we will be able to allocate more individuals that are on the urgent or that are in the urgent category.
Well, just personally, I think it's a good idea to reserve slots for that purpose. Another item that came up subsequent to sending out this agenda, Frankie had a question regarding the use of non-emergency transportation funds from Medicaid, which I realize comes from the Department of Transportation, but it is Medicaid dollars for other kinds of activities. Frankie, would you like to expand on that?
Yes, if you don't mind, thank you. Me and my caregiver had sent the Governor Bashir an email, because the way it works right now in Kentucky, whatever department at Medicaid pays for the non-emergency medical, they pay the transportation cabinet in Frankfurt to make sure that they find the company that can support the need. And right now, the way the cabinet got it, they're getting a huge amount for the number of people that's on Medicaid. So they hand a huge amount to the companies, and they just made sure everybody that's on Medicaid gets a ride. But if you have a vehicle, you're not able to use it. So I'm wondering if they get paid either way from the salary that they give these companies, and it doesn't cost any more. What, if we could make it to where we can use it for activities as well. I don't know if that makes sense.
Yeah. Yes, it
Rick-
makes sense. And I think what you're referring to are the transportation brokers, correct? These companies that get the money on a per capita basis and, right? Is that probably what you're referring to? Like, here's Federated Transportation.
Yes, sir. Like for example, they'll let you volunteer, but they won't take you to like work or to like Walmart or anything like that. So they'll only take you to volunteer day programs and the doctor. But from what, like for example, I don't volunteer today, so they get that money out of that lump sum for the capitated just in case I need it. So I'm just basically wondering if we might be able to change that to where, since they get the money anyway, why we wouldn't be able to use it for non-medical.
Right, right. You're referring to like surplus funds that the broker might have.
Right.
To use for other purposes. I suspect they want to keep it for themselves, but I could be wrong. What does anyone from Medicaid want to comment on that? Are there restrictions that would prevent that from happening, what Frankie is suggesting?
So I think, Rick, what needs to happen is we'll need to postpone this to the next.
Pam.
Yes.
Becky is on.
Oh, it's Becky. Okay, okay.
Yes.
You did
I'm
know,
sorry,
and okay, I didn't
mean
know
to
if you
cut
didn't
you
know.
off.
No, I didn't know that you had known ahead of time enough to get somebody on. So I didn't see that Becky was on. Okay.
No worries. I received the governor's email about a week ago, and we
Okay.
had reached out. Sorry about that. I didn't mean to cut you off.
So we have someone to speak on that?
Yes. Hey, this is Becky Downey. How is everybody?
Thank you. Good.
As of right now, from what I have been told, Medicaid does not pay to transport anybody to other activities. They take them to the doctor. I do think sometimes they can take them to the pharmacy because usually that's a need along with the doctor's office. But as of right now, Medicaid doesn't cover to take them, like to the grocery or Walmart or, to drop them off at somebody's house or something. As of right now, we don't do that.
Right.
And I don't know, I haven't heard anything about that changing.
Yeah. Well, that would require regulate. I mean, is it possible from the federal point of view? Is it something that we could address with a regulation? It seems like these brokers, they might have like a fleet of buses and they might be sitting idle and the driver's sitting idle, and maybe they could address some of these needs. Is that kind of what you had in mind, Frankie?
Yeah, sorry, it took me a minute to get off mute, but that's sort of what I had in mind. Cause me and my caregiver did an open record request to see how much they paid. For we're not supposed to share that information, but it is a good amount, and I'm just wondering, like from where, if you have a vehicle, you can't use it. So I'm assuming there's money left over.
Yeah.
So they still get that money just in case. So when you have a vehicle, you can't use it. So it sounds like there's money left over that the broker could use.
Or even for employment purposes, right?
Yes, sir.
And Rick,
Well,
there's also,
unfortunately,
I think,
the
Rick,
General Assembly is closing. I think this might be require a law change. And it's something that perhaps we can, speak to legislators about what you're saying, Frankie, and see if that's possible. Was there another comment out there? Did you say something, Becky? Did I cut you off?
No, no, you're fine.
Did anyone else want to comment on this issue? And transportation could also be provided through waiver services, yes. But there's a lot of people with disabilities who don't have waiver, but I understand that, Pam, thank you. Anyway, it's something that you may want to work, Frankie, with some other advocates and see if maybe some legislation can be put together that would address that.
Rick, I was gonna, can I say something about it?
Mm-hmm.
It seems like a fundamental question is the NEMT service. Does each state Medicaid agency determine the parameters of those? And so is it a Medicaid decision about what trips can be provided or covered under NEMT? Or, again, does it require, something more like a federal approval or
Yeah, that's what I was getting at. I don't know if it requires the federal government to weigh in
or
not.
or a change in statute, or is
Yeah.
it simply what the Medicaid puts in its transportation plan or state plan, or whichever one of those areas governs it? So I don't know the answer.
I don't know that either. That is a question I'd have to take back to upper management for you.
Okay. Oh, I can make a quick comment on that real quick if you don't mind. It's Frank, by the way.
Mm-hmm.
I promised my daughter what they told me, but the way she was telling me, it is a federal law that it has to be provided for like medical trips, but each state gets to decide like what trips they want to provide and what trips they don't want to provide.
Well, maybe this is something that the DD Council and ARC and some other organizations could look into and take up and see if there's legislation that could be created here in the state that would help with this issue.
Rick,
I think it would take some kind of legislative change, I'm sure. Yes, someone's commenting here.
This is Erin. As Kelly and I are also the SPA coordinators, the state plan amendment coordinators. So anything that would, and of course I would have to do a little research and rely on Becky as well. If there was anything in the state plan that would need to be amended around the NEMT would require CMS federal approval.
It requires CMS federal approval.
Yeah, so CMS, I always say federal approval after I say CMS for some reason. So yeah, if there was any changes that had to be made to the state plan, that does require a change. So through CMS and approval. I do know that. Now, whether or not what is being asked is laid out and where, that I would have to get with Becky and we'd have to do some research and get back to you.
So we'd have to jump through that loop first.
Rick, this is Leslie. I was just going to mention too, that for the most part, I think if it's listed on the plan of care, like if it's a specific item, even if it looks social in nature, but it might be related to a specific goal and task that they're out working on, when it's included on the plan of care, right? I think it's usually covered. But Erin is totally right. If we go outside of the norm of what CMS would allow us to do, then we have to ask for either a SPA change to be approved or a waiver to do that. I think SCL doesn't SCL have transportation in it too now?
yes. It does.
Okay.
It does have a transportation service. And I think just to clarify, when you were speaking about if it's on the plan of care, that's related to waiver, not necessarily to NEMT. So
So you may be able to get the transportation in a plan, but right now it doesn't, we don't compel the non-emergency transportation providers for providing that transportation.
they
Right.
would not be providing it. It would be the waiver provide. It would be
Right.
the waiver provider.
Right.
Sorry if I made that sound confusing too. When I think about a particular service that you might be going out into the community and working on something that may be social in nature. That's what I meant, as long as it's on the plan of care. So I'm sorry if I misspoke.
Well, I don't know. I think there has been like some significant increases in reimbursement rates for non-emergency transportation, and maybe, I don't know, maybe something can be done to apply some of these maybe excess monies for other good things. But we'll keep an eye on that as we go along. Okay, Frankie?
And then, if you don't mind, can I ask one more quick question
Sure.
for Pam? I'm so sorry. I just want to make sure I understood it correctly, because this is the way I understood it as well. Like if it's in the plan, because non-EMT takes me to volunteer because it's in the plan. But like, let's say I wanted to go to Walmart, something like that. Like the caregiver would have to provide that, and not the Medicaid.
That's what I'm getting. Yes.
Yeah, it would be that, that your caregiver could provide that. And it is part of that because it's part of that. So I think, Frank, you probably under the personal assistance service that is part of the services they can provide. So, under your plan of care, if you have, that you want to do your own grocery shopping, or you want to, something about that in your goals and objectives, then that, absolutely is covered for your caregiver to transport you to do those types of things, as well as if you want to, for when you volunteer.
Right. Well, Frankie, like everyone on this committee, you will send out a notice about meetings, and I asked for suggestions for topics to discuss. And if, as things go along, if you want to bring this up again, you're very welcome to do so. Okay.
Okay, thank you.
Sure. Is there any other business?
Rick, can I just point,
Sure.
Just to point out.
I'm sorry. Yes. Yeah, you mentioned about waiting lists. Now, I noticed on the website, if you scroll down, is the waiver capacity and waiting list is on the IDD task force or IDD technical advisory committee website. The one that's posted there now, Pam, is that fairly up to date?
I'm assuming, I'm not on that website right now, but that it's probably from the last, that it probably was from the last time it was updated.
Okay, so anyway, it contains that visual presentation about how big the waiting lists are. I think it's an excellent it's an excellent tool to figure out what's going on with waiting lists. But you're not sure if there's been any updates to that?
I don't think that has been updated. I have the current, and I can get that updated and we can get it posted. I have the current. I've just got them up on my screen right now. I'm just looking at them on the dashboard right now, so I can give the numbers to you.
Okay, go ahead.
And then we can, okay. So for ABI, long-term care, there are 5 individuals on the wait list. See, SCL, I gave that a little bit earlier, but there are a total of 3,477. 38 in the urgent category, 3,439 in future planning. For HCB, there's 1,945 individuals on the wait list.
Mhm.
And Michelle P is, there are 9,009 individuals on the wait list. I don't have the counts of the child versus adult, but it's holding steady right about that 70% that are under 21. And
Yeah, and I
then,
would encourage everyone to look on the website. This is a really excellent thing that the department has done. It kind of puts that waiting list in perspective. I think it's very helpful. Is there any, if there's not anything else, we are adjourned. Thank you.